Hello everyone. Now today we will be discussing the continuation of our diuretics, and previously we have discussed the diuretics that act on the proximal condylar tubule. There is nothing that will act on the distal descending loop of Henle and loop of Henle. So now we'll come to the thick ascending loop of Henle, and where there is a sodium potassium 2 chloride pump that was responsible for absorption of all sodium, potassium and 2 chloride and bring it into the interstitial fluid. It is not permeable to water, so it was contributing in medullary hypertonicity, and which was actually helping us to reabsorb the concentration of urine and reabsorption of water. That is main important of this sodium potassium 2 chloride pump. It helps in the absorption of sodium potassium 2 chloride and also maintain the medullary hypertonicity, which actually help in the concentration of the urine. So let's begin the physiology. If you take the part of here, then what is here? Here is sodium potassium 2 chloride. The sodium potassium 2 chloride pump will co-transport, that will co-transport it inside the cell. You know that there is a this is cell, this is the lumen where urine is there. Okay, and this is basolateral membrane, which is ATP dependent. Sodium is taken out from the cell, potassium coming. Since sodium is lagged, that this pump will precipitate, will compensate the sodium over here. The sodium will be reached into the cell. Now since potassium has reached into the cell, here also potassium coming, potassium will be increased. That potassium will leak out into the lumen. Since potassium will leak out in the lumen, there will be positive potential in the lumen, and since there is a positive potential in the lumen, you know everything are neutral. The sodium potassium, so 2 chloride is absorbed, so it is actually neutral, but when potassium only leak out, then it's become positive charge, positive potential inside the lumen. And since there is a positive potential in the lumen, this positive potential will help this calcium and magnesium to be get reabsorbed from the from paracellular space, and that is important. Okay, so we are talking about normal physiology, which was sodium reabsorption, potassium coming in, sodium ATP is per pump. The main was sodium potassium 2 chloride co-transport goes into the cell, potassium leak out, maintain the positive in the lumen, in the urine. Positive potential cause the calcium and magnesium to be reabsorbed through the paracellular space. This is normal physiology. When it comes to the pathology, when we are going to use the loop diuretics, what happened? This loop diuretics will inhibit this sodium potassium 2 chloride pump. So now what happens? Sodium potassium 2 chloride is not getting absorbed into cell. Since sodium potassium is not getting absorbed into cell and they all are neutralized, potassium is not coming out from the cell. There is no positive luminosity. Okay, so everything will be neutralized. Since it is neutralized now, calcium and magnesium will not be absorbed from your paracellular space, and this will loss in the urine. So this will lead into the hypomagnesemia. Even calcium will be decreased, but that will be again recompensated in the late distal part of the condylar tubule, that will get again reabsorbed. Okay, so there will not be significant hypocalcemia, but magnesium will not reabsorb other than this place of your thick ascending loop of Henle. We are talking, not beyond that. So hypomagnesemia will occur. Okay, so you have understood loop diuretics. So there will be a hyponatremia, hypokalemia. This all are going to be lost. Okay, and since sodium is going to be lost in the late part of the tubules, sodium will reabsorb, potassium will be excreted. So side effect will be hypokalemia, in our case hypomagnesemia. Okay, then you know that furosemide groups of diuretics are ototoxicity. There is a dehydration. These are the sulfur drugs will be allergic. There will be metabolic alkalosis, nephritis, interstitial and clot. These are the side effect of your loop diuretics. Let's begin from the mechanism. Once read it and then we'll understand. Okay, so we'll divide the loop diuretics into two groups. One is sulfur group, is non-sulfur group. Okay, sulfur group is why we came with this non-sulfur group. We know that the furosemide is the most commonly used diuretics. Then why we came with this non-sulfur? As it is a sulfur drug and most of the people have sulfur allergy, so there was the development of this non-sulfur drug, which is known as the ethacranic acid. Now let's talk about the loop diuretics. Loop diuretics is furosemide, torsemide and bumetanide. Okay, bumetanide. Now the mechanism, you know that it inhibits the sodium potassium 2 chloride pump. This is inhibited. So there is also abolish the hypertonicity of the medulla, preventing the concentration of urine. You know that this sodium potassium 2 chloride was come into the cell, the urine here come into the cell, then what happened? The concentration increases over here, medulla concentration, which get equilibrate with this, and again the vasa recta will take here and concentration will, medullary concentration will reach here, and according to this, if it is 1200, then maintain the concentration of urine. If you are not understanding this, please go in the previous lecture. You will have one lecture on counter current mechanism. That is very important to understand the renal physiology and all the diseases. So this I am talking about counter current mechanism. You will understand there. So counter current mechanism cannot be maintained. So there will be preventing the concentration of urine. That is important. Okay. Now it also stimulates the release of the prostaglandin, which cause vasodilation of the afferent arteriole. Okay. And there, so afferent arteriole vasodilation, there is increase in blood flow, and even in low GFR, this is actually we can use the furosemide group of the loop group of diuretics. Okay. Now since this is not working, now calcium and magnesium will be not be absorbed, so they will be excreted in the urine. So urine excretion of calcium, that is loop diuretics lose the calcium. Okay. Now what are the clinical use? You know that clinical use is any edema, edematous states like heart failure, cirrhosis of liver that leads to the edematous status of your body, nephrotic syndrome, again edema all over your body, pulmonary edema, very useful drug. Severe pulmonary edema, furosemide will create magic. So this will remove all your alveolar fluid, all your pulmonary edema and passes through the urine. Okay. Then hypertension and hypercalcemia. Since calcium is lost in the urine, so we can use, if the calcium is more in the blood, then that can be lost in the urine. Okay. But if there is a stone disease, then this will precipitate the stone. So you have to avoid. You need to know what is asking. It is asking hypercalcemia, then okay, you can use. If it is saying there is renal calcium stone and you are using furosemide, then calcium is more excreted in the urine, then this will get again deposited over the kidney and cause again more stone formation. So you should avoid stone patient this furosemide group of diuretic. Okay. Now coming to the adverse effect, you know ototoxicity, hypokalemia, you have understood, magnesemia, loss of magnesium, dehydration will be there, allergy to sulfur drug, metabolic alkalosis, nephritis and gout. Okay. Now if you cannot use this sulfur group of drug, then we have to use something as it is high potent diuretic. Okay, so there will be another non-sulfur drug that can be used in case of this sulfur allergy. Diuretics in the present allergy to this sulfur drug, and the mechanism will be same as it is one of the component of one of the type of two diuretics. Okay, clinical use will be allergic to the sulfur drug. You have no adverse effect. It's almost same. Only the ototoxicity of this ethylpranic acid is more than that of other loop diuretics. Okay, so I hope you have understood all these things. This is very easy but very important. Okay, so let's end over here. Then we'll discuss other diuretics like diuretic acting on distal conductivity and collecting duct in next video. Thank you.